Thank you very much. I really appreciate the opportunity to be able to come and speak to you today through the FSH Society. I want to talk to you in terms of the respiratory pump, the muscles of breathing, and really speak to the fact that these forums are really educational opportunities, and we as clinicians need to provide education to you to better understand or help you understand how neuromuscular weakness, particularly muscle weakness, affects the respiratory system and what are the important aspects of the function of the respiratory system in order to best take care of yourself. Because in the end, we can prescribe things, but it's your best understanding of how therapies work in relation to the effect that muscle disease has on the respiratory system that will enforce your ability to use these therapies to your best benefit. So I want to talk about the mechanics of breathing and the respiratory pump, which really comprises the diaphragm, the primary breathing muscle underneath the lungs, but also what we call the accessory muscles, the muscles of the chest, and as well the diaphragm, the abdominal muscles, but also the muscles of the throat, because this is the gateway to the respiratory system. And all these muscles have to work at a reasonable point to be able to allow us to be able to get the best support that we need. So breathing obviously is important because this is what oxygenates the blood, and this is important in our heart health as well, and I'll show this in a slide shortly. But it also has to do with release of carbon dioxide, the waste product of our metabolism. If we don't get rid of that carbon dioxide as well as we need to, if we're not breathing efficiently enough to do so, then this is going to affect our sleep quality. It will limit our ability to get into REM sleep, the deep sleep that we need in order to be able to have the best daytime wakefulness. We also need to sigh. We need to have muscle strength to be able to inflate the lungs. If we don't do that, the lungs will actually start to collapse. And this occurs particularly in the lower parts of the lungs, and this collapse can actually predispose us to a greater potential for respiratory infection. So if we don't have the muscle strength to take a deep breath in once in a while, and we do this automatically, we don't think about it, this is our what we call hyperinflation mechanism that actually allows us to keep the lungs healthy by keeping them stretched, to keep them flexible, and as well to keep them expanded. And we need to cough. We need to be able to cough well enough to clear the mucus that we all produce in our lungs. Lungs are the only internal organ in our body that's exposed to the outside environment by the air that we breathe. There's a lot of particulates, there's a lot of debris that's in that air that we breathe. We need to clear it out of the lungs, and the mucus is what's meant to do that. The mucus moves out of the lungs by what we call cilia that line the airways of the lungs, but ultimately we need to cough and clear it out. And if we don't have the strength to do that, then that is a limiting factor. And that's actually what causes most people to end up in the emergency room with respiratory distress, because if they have a respiratory infection where we produce a lot more mucus than normal, that inability to clear that mucus will result in congestion in the lungs and affect our breathing to the point where we're uncomfortable and we can't breathe well enough. And this is where most patients with breathing muscle weakness may not have been recognized to have a problem and is ultimately present in the emergency room with this problem. So traditionally, neuromuscular patients were managed by either neurology or rehabilitation medicine and were referred to pulmonary medicine after the fact. But the management focus was primarily on progressive physical limitations. Neuromuscular associated respiratory weakness was either not considered or not recognized. And this is primarily because of the fact, but particularly in the dystrophies, the muscular dystrophies, that the onset of weakness is so slow that even the patients themselves don't necessarily realize that they're having significant breathing limitation. So patients were most often, again, recognized to have a problem when they presented in the emergency room with respiratory distress because of this congestion that I mentioned. And because of this slow progressive weakness, again, the physicians don't necessarily recognize this. Kyphoscoliosis is a problem that oftentimes occurs in conjunction with that weakness of the abdominal muscles that Dr. Padilla spoke about, as well as the chest muscles, the scapular muscle groups in the back. And so this can occur in two ways. There can be either muscle weakness in the lower lumbar area or in the, in the lower lumbar area on the left picture, or in the right, on the left side of this picture in the thoracic area. And if you look at the x-ray, you see what happens. There's actually a compression on one side of the chest that limits the ability for the lungs to expand. So this is what's called chest wall restriction, and this is a result of that chronic progressive weakness of the muscles of the chest that allow for this to occur. So this not only causes a restriction, but also limits the ability for the muscles of respiration to be able to ventilate us as well as we need to. So FSH muscular dystrophy then has, as a slow progressive muscle weakness, the kyphoscoliosis often occurs. Respiratory symptoms are not always apparent. And so periodic respiratory assessment is something that's really necessary. And the good news is that there have been a couple of consensus statements that have been developed, one by the American Thoracic Society, headed by Dr. Jonathan Finder in Pittsburgh, that really developed a kind of a protocol. And although this is meant for Duchenne muscular dystrophy, it's a template that can be used for any of the muscular dystrophies in order to be able to monitor people's breathing function and be able to determine when therapies are necessary. Also, more lately, the CDC has come up with guidelines. So the goal then is to initiate timely respiratory support according to the limitation, and with breathing assessment, you can do this. Now, this involves a number of different types of tests. You can use either spirometry or what we call vital capacity testing to measure the global respiratory function, both the muscles of inhalation and exhalation, or you can do either as well pressure testing, and you can separate out the muscles of inhalation by doing negative pressure testing. We breathe by drawing air into our lungs, so we create a vacuum, and you want to measure how strong that vacuum is. And we can also measure how positive pressure by exhalation using the abdominal muscles and the muscles of the chest wall to expel air out, and particularly this is important with cough, to be able to assess how strong those muscle groups are. And if they're weak, then we need to determine what is the appropriate therapy. We can also look at the efficiency of our ventilation. How much air are we moving in and out over the course of time? And this relates to that exhalation or getting rid of carbon dioxide. If we're not doing that well enough, then carbon dioxide will back up in the blood, and again, it affects our sleep quality. So arterial blood gas testing, where you draw samples of blood from the arteries, has been the traditional means of doing this, but this is very uncomfortable and oftentimes difficult for neuromuscular patients. So you can also use what's called end-tidal CO2 monitoring, which is what you see the patient using a small nasal cannula. Basically, some of the exhaled gas from the nose is drawn through the machine. It measures CO2 non-invasively, much more convenient, much more comfortable, and as well accurate. We did simultaneous studies with blood gases and we're able to show that there's good correlation using this means of monitoring. So a CO2 over 48 would be considered a CO2 that's starting to back up in the blood and points to the inefficiency of our breathing function. We can also, and we need to also, measure cough, and that cough can be measured by the velocity of cough. How fast can we expel air out? And this can be done with a very simple measurement by what we call a peak flow meter. The device that's in the upper right-hand side, it's just a peak flow meter with a air cushion face mask. And if you looked in the previous slide as well as in this slide, face masks can be used to implement these tests. Certainly with FSH, there's oftentimes an element of facial weakness, and this is thought to preclude the ability to be able to measure as well as you need to. But in fact, we find that we can get very good measurements by using a face mask as a means of an interface to be able to administer these tests and get the information that we need in order to best assess the patient. So a peak cough flow of 600 to 800 liters per minute is what's considered normal. And if you can't generate greater than 270 liters a minute, then that's kind of it's a soft call, but it's probably the best that we have in indicating that on a day-to-day basis, you can probably cough well enough, but if you develop a respiratory infection where you have a lot more mucus and you need to cough more often, those muscles are going to be taxed more and more. They're going to become more fatigued, and you're going to lose the ability to keep up with clearing that load of mucus. And if you can't generate a peak cough flow of 160, then that's really considered cough insufficiency. And we need to implement cough augmentation therapy. So again, breathing muscle weakness and chest wall restriction are the two things that we see in terms of limiting our respiratory function, our ability to ventilate as well as we need to. And this is usually seen at night when we're sleeping, because this is when we all breathe more shallowly, and this is when any kind of weakness will show up in terms of increasing our CO2 level. These are a number of symptoms that you oftentimes see. AM headaches. We wake up in the morning with a headache. When we awaken, we start breathing more deeply. That headache will go away. Frequent awakenings at night. Restlessness because we're not getting into that deep REM sleep. Nighttime sweats are sometimes as well occurring. Daytime lethargy, or just not feeling like you've got any energy because you didn't get good sleep quality, is another hallmark. And as well, poor concentration, the inability to be able to stay concentrated on what you're doing. This oftentimes occurs with students, where we found that if you implement a therapy, you can actually improve their study concentration, and patients have actually increased their grade point average, with the appropriate therapy, believe it or not. But also, in a sizable percentage of the FSH patient population, there's upper airway weakness that can occur that results in what we call sleep disordered breathing, some constriction or restriction of the airflow of the upper airway during sleep that affects the ability to move enough air in and out of the lungs that, compromises our breathing, that affects our ability to be able to breathe as well as we need to, and affects our sleep quality. So this is that example that I wanted to show you about the heart. The top profile is actually a profile of oxygen desaturation events. And you can see these where there's some restriction or weakness in the breathing that causes either upper airway or muscle-related hypoventilation or shallow breathing that affects our oxygenation. And then if you look at the corresponding heart rate down below, you can see the response to each of those desaturation events. So the heart is working harder. There's a good correlation between this work of breathing and heart function. If we're not saturating and we're not carrying enough oxygen in the blood, the heart is going to respond by pumping harder. It's going to be working harder. We're putting pressure on the heart. We need to support adequate breathing at night in order to support our heart health. So how do we determine that there's a problem? Well, you can do what's called a sleep study. Sleep studies are two parts. There's a diagnostic part to determine whether, in fact, there's sufficient sleep disordered breathing to warrant some support. And the second part is actually doing what we call a pressure titration study. Now, sleep disordered breathing can come by two different ways that we talked about. The weakness of the upper airway that affects our ability to move air in and out, or the weakness of the muscles of breathing that affect our ability to ventilate and move enough air in and out of the lungs. If you can either have an obstructive upper airway or combined chest hypoventilation issue that limits our sleep quality. If, in fact, the diagnostic study shows that there's some significant sleep disordered breathing, then you do what's called a titration study. You need to adjust the pressure. If the problem is only with regard to the upper airway, you can use what's called CPAP, continuous positive airway pressure. When you breathe in or breathe out, the pressure that you use with a mask allows the upper airway to stay open, and this is what basically supports the problem with upper airway weakness that affects our breathing. If you have breathing muscle weakness, separate or combined with obstructive sleep disorder breathing, then you need to use what's called BiPAP, or bilevel pressure ventilation. Bilevel pressure ventilation is a means of augmenting our ventilation to be able to breathe well enough at night. And so what was done a couple of years ago was another consensus statement by a group of physicians, pulmonologists, and sleep specialists that recognized that the neuromuscular patient population was not necessarily being cared for as well as they needed to when they were referred for sleep studies. Sleep studies can evaluate sleep disordered breathing and then provide the therapy to support or to try to address this problem. But more often than not, again, the clinicians didn't necessarily understand how well to care for patients that had particularly the hypoventilatory or the shallow breathing weakness as a result of the respiratory pump. And we needed to help them with that, so that this consensus statement allows for a template to be able to provide a good sleep study in terms of the pressure titration and determine whether CPAP or BiPAP is the best support. So again, if we look at those three things, breathing, sighing, and coughing, we'll talk about the bilevel or the non-invasive ventilation first. So bilevel pressure ventilation is meant to support breathing at night while we're sleeping. It's meant to decrease the CO2, but it also supports muscle rest. So as Dr. Padaya was talking about, resting the muscles, this is also important in terms of the muscles of respiration or the muscles of breathing. We need to rest those muscles at night if they're weakened to the point where they need support. And this is what we're doing with BiPAP. It augments our breathing so that we don't have to do all the work of breathing. And this allows the muscles to rest at night so that during the daytime they have more strength to work over the course of the daytime hours. There are a number of different devices that can be used for this support, and these are just two devices. So this machine has the pressure unit and a humidifier. We need to warm and humidify that air because otherwise our mouths and our throats will dry out. So it's an air conditioner, if you will. And the machine is set at pressures that are meant to either take care of this upper airway issue or to augment our breathing. But the point that's important is that they're very convenient systems that allow you to be able to travel. They're not something that can preclude you from being able to be out and about and do what you want to do. So they're very, very portable systems, and they basically allow you to be able to get the therapy you need in as mobile a means as possible. So we talked about the BiPAP. This is two components. The IPAP is when you breathe in, you get a higher flow of air to basically allow you to breathe without as much work. And the EPAP is the expiratory pressure that basically allows you to breathe out but washes the exhaled gas out of the mask that you wear. These types of therapies are administered by a mask. They're therapies that you consciously use to be able to augment your breathing. And you have the ability to apply and remove the mask on your own. Certainly, all of you out there who wear glasses like myself are used to taking your glasses off at night when you go to sleep. We're not used to putting things on our faces to go to sleep. So there's a bit of a acclimation that needs to be done in order to get used to this. And so doing this on a slow kind of self-directed process of acclimation is important, because if you just try to go to sleep with this at night, it's a recipe for problems. You need to be able to get acclimated to the therapy first. There are a number of different types of masks that you can use for this therapy, and so this is just a selection of them. This is, again, a technology that's increasing both in terms of the materials as well as the designs to be able to help us get the best support that we need. So we want to talk about sighing now, again, that hyperinflation. How do we do that? Well, you can do it by a number of different ways. And hyperinflation therapy is important because if we don't breathe enough, if we hypoventilate, the lungs don't get expanded and they lose their flexibility. Again, how do we breathe? We draw air into our lungs. If our lungs don't maintain good flexibility by getting those sigh breaths in, they'll start to get tighter. And if we're having to breathe air into tighter lungs, then it's going to affect the work of breathing. It's going to make what muscle strength we have taxed even more. So we need to be able to do something that allows us to be able to hyperinflate the lungs. So think of this as range of motion for the lungs and chest wall. You can actually improve the lung function by by doing hyperinflation therapy. This will decrease the atelectasis, improves lung and chest wall flexibility, and this was been shown by Noah Lexon at Johns Hopkins, and it's also been shown in a number of different other studies where patients were put on BiPAP, that support of breathing, when they were otherwise not using this therapy before. And with that positive pressure breathing, helping the lungs to expand, they actually improved their pulmonary function tests because they got muscle rest and they got chest wall and lung expansion exercises. So this is a hyperinflator device. It's just a simple resuscitator mask with a couple of one-way valves, a flex tube, and a mouthpiece. And this can be used to administer hyperinflation. This is Dr. Doug McKim, and he'll show you how this works.
Just take a big breath in, put the mouthpiece in your mouth, and breathe in, and again, and once more, and let it all out.
So you can see the lung and chest wall expand with that hyperinflation. And a person can administer this therapy on their own, or if you're having difficulty doing this, you have a caregiver help you with this. But what we ask our patients to do is do 8 to 10 of these hyperinflation maneuvers twice a day. And when they do the maneuver, they inflate and hold the breath for 5 or 6 seconds to allow the lungs and chest wall to expand, and then let the air out, take some breaths, relax, and then do another maneuver. But do these hyperinflation maneuvers on a regular basis. So again, the reasoning for, why do you do this? Well, it's replacing a sigh. When we can't take the breath that we need to in order to keep the lungs and the chest wall expanded, we need to use therapies that can help us do this. This is a very simple means of providing that support with a very inexpensive device. Cough. Cough is important, again, because we need to clear the aspirates that we get down into the airway, whether it's gas or liquid or solid. If our mucociliary system is overburdened by a lot of congestion with a respiratory infection, we need to be able to clear that out. So this is what a cough is all about. There are 4 phases of cough. I'm not going to go through those other than to say that it's a reflex reaction, and we need to be able to do it adequately. And if we have breathing muscle strength, cough involves both muscles of inhalation and exhalation. If we don't do that adequately, ineffective cough, is going to be more of an affecting factor in causing us to go to the emergency room than probably anything else, because this is, again, what usually precipitates respiratory distress. Most of you out there, if you are having difficulty coughing in terms of clearing something, and you have to cough more and more often to clear something, or cough more times to clear something, this is probably an indication that there is some degree of compromise in your ability to cough. So cough support can be done by 3 different methods. You can use manual hyperinflation therapy alone, just like we used there, and allow the elastance of the lungs and chest to expel the air out as best you can. You can use hyperinflation therapy in conjunction with an abdominal compression, or you can use what's called mechanical in-exsufflation. And this is an example.
We'll first use a pillow to stabilize the head. Check for optimal body position and landmark for the assist. Take a big breath in, put the mouthpiece in, and breathe in, and again, and again, and
So that looks almost uncomfortable. But actually, caregivers can do both the compression and the hyperinflation together. It takes a little bit of coordination, but once you get it down, it's not that bad. And, it looks uncomfortable, but I'll tell you right now, if you take a deep breath in and you put your hands in the lower abdominal area and you just push the breath out, there really isn't any discomfort there. If you move higher and hit right below the sternum, that's kind of like the sucker punch, that really does hurt. That can be uncomfortable. But if on a coordinated effort, doing the hyperinflation therapy to get as much air in the lungs as possible, and then to compress the abdomen and push the air out, only takes, basically takes place of our muscles of breathing, both inhalation and exhalation respectively, to clear the mucus that we produce. So this is a very effective and very portable means of cough augmentation. So mechanical in-exsufflation is basically using a machine that kind of mimics a cough in reverse. By that I mean it actually gives us a volume of air under pressure, and then it pulls the air out in order to clear the mucus. So this is a device that when you compare it to doing the hyperinflation alone, and hyperinflation with the abdominal compression actually does the best. And this is what usually keeps our patients out of the hospital when they do develop respiratory infections, using cough augmentation mechanically. And this is an example of that. Let's show you how this works. Watch the patient's chest when the cough augmentation is administered to them.
Your neck is well supported?
Yes, it is.
In, cough, out, out. In, cough, out, out. In, cough, out, out. In, cough, out, out. In, cough, out, out.
So what Carol's done is actually kind of verbally walk the patient through the therapy so they know, and it's going to go from positive pressure, helping them take that deep breath in, to going to exhalation to clear the mucus out. But this is a very effective means of clearing mucus out of the lungs. And it really is our cough that ultimately needs to be able to clear mucus out. And again, if we are able to do this well, then most any neuromuscular patient who has breathing muscle weakness can weather the storm of a respiratory infection. I'm going to talk only about one more thing and stop here because of the time element. So having a contingency for respiratory infections is really important. This is a kind of protocol that was developed by Dr. John Bach in New Jersey, who's a physical medicine physician who really is an ardent proponent of respiratory support for patients, because we know that really respiratory aspect of neuromuscular weakness is the most life-limiting effect for patients. And this protocol employs just using a simple little finger oximeter. And these can be purchased through medical providers on the internet for around $35, $30. It amazes me how cheap they are compared to what they were 3 years ago when you couldn't buy one for less than $400. But literally, if it's an FDA-approved device, it should be adequate. And if you have good perfusion to the hands, in other words, the hands aren't too cold, so that you get a good signal, because this is a non-invasive means of measuring your blood oxygen saturation. If you can't maintain a saturation of 95% or better in conjunction with symptoms of a respiratory infection, this would indicate that you are starting to develop some chest congestion. And so what do? Well, in our clinic system, we prescribe a broad-spectrum respiratory antibiotic for our patients. We want them to take that. It could be a number of different alternatives, but a respiratory infection may well be a bacterial infection. We don't want a chance that it's not a bacterial and a viral. We'll just give the broad-spectrum antibiotic. And then we use that cough assist, the mechanical in-exsufflation, to clear the mucus as needed, and as well, if the patient is using BiPAP, to provide that as well to weather the storm. We have much less than 5% of our 300 plus patients in our system ever hit the emergency room for respiratory problems because we use this protocol. Some physicians, wherever you're at, may be a bit reticent to do this. Oftentimes they don't want to administer antibiotic therapy, but having the combination of antibiotics and the means of cough clearance to support you will limit your ability to be able, or to have to go to the hospital and treat the respiratory infection in the hospital setting. So a cough assist device is about $6,000. your incident at the hospital with a respiratory infection is going to cost well more than that. So this device is very cost effective in terms of helping people to weather respiratory infections and to stay at home to do so. And I think I'll stop with that.